And we're back with Nate Henderson. Nate, it's exciting to have you back on. You've been on once. For people who haven't listened to the first episode, it was me, you, and Mark discussing an article that you published on E3, and we had an associated podcast episode on the topic. I would strongly recommend people listen to that episode. I thought it was great, the three of us chatting about what you wrote. It was episode 187, Should Rehab Be Pain-Free? For people who haven't listened to that episode and maybe aren't familiar with you, can you tell us a little bit about yourself?
Yeah, so my name is Nathan Henderson. I've been an outpatient sports and ortho physical therapist out here in Bozeman, Montana at Build Physio for almost 3.5 years, and then have been a part of the E3 team for just under 2 years now. Been working with a lot of post-op ACLs and a variety of other sporting contexts out here, and excited to talk about all this stuff now.
Yeah, we had, obviously you've been on previously. We've had your boss and the owner of Build, Laura Obstedal, on previously talking about force plates, and the amount of ACLs you all see is very high compared to a lot of clinics, even if they're sports med clinics. And the reason I wanted to have this discussion is because you all recently published, just a few days before this recording, a screenshot and a share of your experience with the three main grafts and the different strength that is present on average with these three grafts at the 6-month mark, and the percentage difference and compared to body weight. And I think it's going to be a great conversation of the pros and cons of these different ACL grafts, what you've experienced, how you've kind of evolved maybe your decision making and plan of care based on the differences. So I think it's going to be a good conversation. Before we dive into those three main grafts, can you just highlight what the difference is and what are autografts versus allografts?
Yes. So when you're deciding when you're going to get an ACL reconstruction, you tore your ACL, you're choosing to go get surgery, you then have to pick what graft am I going to have. So there's a couple big options. First, grouped solely by themselves are allografts, also known as cadaver grafts. So this is where you're not taking anything from your current body, another part of your knee, in order to make your new ACL. You're using a part of a cadaver, oftentimes an Achilles tendon, patellar tendon, quad tendon, rarely a posterior tib or anterior tibialis tendon, and you're putting that into your body. The downside of that is it's unfortunately a slightly weaker tendon, so they don't do it for young active people returning to level 1 cutting sports. So soccer, basketball, football. It's going to be extremely rare if you're a high school or college athlete to get that graft choice. Oftentimes they'll reserve that for people who are a lot less active or older, where the re-tear rates are about the same. But because you're not taking anything from your own knee, there is no donor site morbidity. There's a lot less muscle shutdown after surgery. And so it's typically a lot easier rehab from regaining muscle strength, size, performance. Autografts, on the other end, are taking something from your own body to then become your new ACL. So the three big types of those are quad tendon, bone patellar tendon bone grafts, and then hamstring tendon grafts. So the quad tendon graft is typically taken from your rectus femoris that leads into your quad tendon, and then depending on the surgeon, may or may not have a piece of bone plug from the top part of your patella in it. Patellar tendon grafts are taken from your patellar tendon just below your kneecap and typically include a bone plug or chunk of bone from both your patella, your kneecap, and the top of your shin, your tibial tuberosity. And then finally, hamstring tendon grafts are taken from your semitendinosus graft tendon and are often supplemented with either your gracilis tendon, or if you have a small hamstring, if you're a younger patient getting that graft, they'll add in parts of a cadaver graft to supplement that to make it the appropriate size for you and your ACL.
And the reason the autografts are preferred for younger individuals, for athletes going back to high level sport, why are the autografts preferred over allografts?
So typically it is one, less likely for your body to reject that graft because it is part of your own body. Every so often you'll get a body rejecting an allograft and it'll end up just dissolving and you don't have an ACL again, despite not re-tearing it. The bigger reason, however, is it is a stronger graft, being a little bit thicker and part of your own body. So quad tendon and patellar tendons are extremely strong. The quad tendon's a little bit thicker, but may or may not have a bone plug. patellar tendon a little bit thinner, but has a bone plug on each side, means it's really good healing. And then the hamstring graft isn't as strong as those other two, but still tends to be stronger than a cadaver graft in and of itself.
And out of these three main autografts, the bone, patellar tendon, bone, the quad tendon, and the hamstring, is there one in 2025 that's still considered the most utilized or the gold standard, or is it vary by region?
So I'll say there's been some trends throughout the past 10 or 20 years, but it is still very region specific, at least in the United States here. It often depends on where surgeons themselves went to school, who they trained under, what grafts they preferred, as well as then as they progress in their practice, which ones they choose. So, general rules of thumb: Pacific Northwest traditionally had a lot of hamstring tendon grafts, Northeast had a lot of patellar tendon grafts. The patellar tendon graft has been the gold standard for a very long time, 20, 30, 40 years. The hamstring graft had a big push 10 or 20 years ago, promising faster return to sports because you aren't taking anything from your quad or from your extensor mechanism. And so you can get your quad strength back a lot quicker. However, people then realized they're going back to sport a lot sooner and then they're re-tearing more and more. So that's backed off a lot more. So it's going to be relatively rare for you to see a hamstring graft in a very high level athlete now, at least in the US. And then finally, quad tendons have had a really big push in the past 10 or 15 years at kind of reemergence, where a lot more surgeons are doing that now.
Let's dive into each three, the pros and cons, where the research stands, your experience, and y'all's testing at Build. Starting with the bone, patellar tendon, bone, where does, you mentioned it a little bit, where does the research generally stand on these? And that's a broad question, so you can go wherever you want. And then we'll go after that, what generally has gone well with these rehabs out of the ones you've seen, and what has been more of a challenge?
So, talking bone, patellar tendon, bone graft, starting kind of from the beginning of rehab all the way through. So, typically, patients with this don't struggle getting their early extension range of motion as much because you're not taking anything from the hamstring that might tighten the hamstrings and limit knee extension. It's a little bit smaller of a graft than the quad tendon graft traditionally. So there's a little bit less likelihood of getting a cyclops lesion where you can then limit extension because of that and increase pain, have to go get another surgery to get that cleaned out. I do tend to see, at least in our population, a little bit less quad shutdown than the quad tendon graft, at least from the start. However, you do struggle with then a lot of donor site pain early on if you aren't managing that appropriately. Flexion range of motion early on with patellar tendon graft tends to go pretty smooth, pretty easily. No big issues with that there. I will say early on when we're introducing knee loading, you do have to be careful with this, similar to a quad tendon graft, because you took a giant chunk out of your patellar tendon. It's usually a middle third of it, and that has to regrow and heal itself. So if you load it up too early, it can really piss off that patellar tendon and take a long time to heal. Coming out of surgery, obviously you have the quad shutdown. You want to start getting that fixed as soon as you possibly can. But you're also dealing with essentially a really, really extreme case of patellar tendinopathy. And so trying to manage both of those at the same time can be really challenging, where you're trying to hammer your quads as much as you possibly can in order to get that quad strength back. But then you also have to not push too hard and set yourself back in the long term by keeping the patellar tendon graft site really, really flared up.
I have a quick question. How do you, and maybe you're going to go into this, but are, like you said, it's kind of a really aggressive, like patellar tendinopathy. Are you treating it like a patellar tendinopathy from a heuristic, from a loading perspective and a symptom threshold perspective?
Yes, for a patellar tendon graft, I do traditionally do that, and it seems to work relatively well. We'll contrast this a little bit later with a quad tendon graft, where I've changed my philosophy and don't do that as much. But yeah, with a patellar tendon graft, once we can start doing things, loading the knee directly in the quad directly, whether it's a wall sit, a wall lunge hold, or any type of open chain knee extension, isometrics, isotonics, isokinetics, I am treating it like a patellar tendinopathy using those standard rules once we get out of the really acute phase where I'm good with a 2, 3, 4 out of 10 pain, as long as it's coming back down to normal when the session is done or by the next day, and it's not increasing over time, and hopefully is decreasing over time with the same amount of effort.
Another question, I think when we had Megan Graham on, we were talking about isometrics. And I asked her about like for these patellar tendons, I think that's what she was seeing a lot of in her research, and maybe it was quad tendon as well. I think it was mainly patellar tendon, but is there a risk with, isometrics early on in this mid range for like a patellar fracture because of just the location of where the graft was taken? And are you or have you experienced any type of, if you're pushing the intensity too hard too soon, an adverse effect with the patellar tendon from a patella fracture perspective?
So that is always a risk just because you're taking a bone plug out of the patella and there is essentially a fracture there. The good thing is that most people after surgery don't have the quad strength or the ability to recruit enough quad strength in order to expose that fracture and actually break it or make it symptomatic and make it a long-term issue. It is always a risk. You always, I think, kind of the saying is it's a rite of passage when you until you get your first one and you do it. I thankfully haven't had one, but I've talked to plenty of really good PTs who have had that happen. So my thing is there's no need, especially early on, to make something a true max effort isometric as hard as you possibly can, kicking into a knee extension machine or any sort of dynamometer. So I'm usually scaling it back a little bit and early on going longer duration, lower intensity holds, adding in things like blood flow restriction, NMES, everything like that, and just not needing to risk that, even though it is a really low risk for that happening.
Yeah, it's somewhat self-limiting, but you're also putting in constraints to where they're not ramping up the throttle too much. Does that change the first entry point for testing isometrically or isokinetically on a bone patellar tendon bone versus another graft, or do you keep the starting point from a testing perspective the same?
We tend to keep it the same. Just speaking as our clinic and what we do, we test on an isokinetic dynamometer, but our first test we're doing at 8 weeks out from surgery is an isometric test at 60 degrees. And no matter what the graft is, whether it's patellar tendon, allograft, quad tendon, hamstring graft, we're not having them push into any pain or discomfort in that first test at 8 weeks. Because no matter what that first test result is, I'm not clearing you to go back to sport or start running at 8 weeks, no matter what. It's just setting our baseline that we can then build off of and see the improvement month by month for that. So starting at 60 degrees, not pushing into any symptoms. Most people aren't kicking more, especially with the patellar tendon graft, more than 50, 60 pounds at the most at that point. So we're fine to stay with that. And usually that isn't symptomatic.
What else? I've stopped you multiple times, but what else with the bone patellar tendon bone do you want to talk about?
I think the other things that commonly come up with it is the kneeling pain and the anterior knee pain with it. I think it's something that you need to be cognizant of throughout the entire rehab and checking in with the patient. Because oftentimes with this, similar to almost like a knee replacement, they just won't kneel on it because they know it hurts and they'll never spend the time slowly exposing it to the kneeling. And so I think starting as early as you can, whether that's 6 weeks out, 8 weeks out, 10 weeks out, whenever they have the comfortability and the knee flexion range of motion to kneel, starting on whether it's a bed, a couch, a foam pad, something like that, and just gradually weaning off until they're able to kneel on a hard surface. I think just being cognizant of that throughout the entire rehab. And that also might be part of the reason why you don't want to irritate your patellar tendon really early on with really high effort quad loads. It's because if you keep it irritated, even if you're exposing it to kneeling, it might always stay extra irritated through that phase.
Anything over the past 3+ years with these bone patellar tendon bones that you've seen where you've modified how you've treated some of these cases?
One thing I've seen with patellar tendons, it's not super common, but I think it is more common with those than with other graft types we've seen, is sometimes they just don't handle a standard knee extension machine extremely well, or even high effort isometrics. And so using some kind of creative ways to load an open chain knee extension, whether it's a flywheel or isokinetically, seems to sometimes make, whether it's the patellar tendon or just the patellofemoral joint, feel a little bit better too.
Do you have any guesses as to why that is? Or you're just like, I don't know, it just feels better?
I have no idea. I think I've seen it with enough patients that If they're saying it doesn't feel great with a normal knee extension machine, I'm not going to force it. I'm just going to switch it earlier than I would with a quad tendon graft, hamstring tendon graft, or mess around with those different variables.
Ready to dive into quad tendon or anything else with patellar you want to touch on?
I think we're good for quad. This will be probably the more fascinating one because it's the newer one, at least for me, the more complicated one as well.
Yeah, let's dive into it. Wherever you want to start with quad tendons.
Yeah, so I think early on it's pretty similar to patellar tendons as far as it's relatively easy to get extension range of motion back. Sometimes a little bit harder with flexion range of motion, at least in my experience, especially for like a prone pulling, bending your knee, or like if you're doing a standing, grab your foot and pull it back, just because it's coming from the rectus femoris, which is also crosses the hip joint. When your hip's extended and you're trying to bend the knee, it can be a little bit tighter. We have seen also early on a greater occurrence rate of cyclops lesions in these than we have in patellar tendon or hamstring tendon grafts. I think it's just because it tends to be a little bit larger of a graft itself. And so it's putting a really big thing into a certain tunnel, and sometimes it just is a little too big and causes that cyclops lesion graft, or the cyclops lesion that you have to get it fixed. We have seen with early on with as far as quad activation, arthrogenic muscle inhibition, quad tendon grafts tend to be all over the place. Some of them do awesome. They're perfect, just like patellar tendon graft or even easier than those. However, we've seen when a quad tendon graft goes bad and they get really bad quad shutdown, it's really bad and can take up to a year to just get to kind of normal quad loading, and return to sport can be a year and a half to 2 years in order to get symmetric strength, which I'm sure we'll talk about with the testing data we've gone through with this. So a good quad tendon graft, whether it's a high school or college athlete, good surgery, they did some pre-op rehab, and they're good to go. It can go awesome. But the handful that we've had that go bad, it's been a really hard struggle to get them even close to normal again.
What have been some things during those more challenging rehabs that you all have experimented with that have proven useful?
So I think we've tried all of the things that have been shown in research for arthrogenic muscle inhibition, AMI, to help out. And I do think those have helped really well with some patients, whether it's prefocal cooling, icing that knee joint before you're starting to do quad loading. I remember this must have been 2.5 years ago at this point. I had a patient who was 8 weeks out and was really struggling, and was one of those ones that was going to take a really long time to get back. And so I did a little mini experiment in the clinic where I did her 8 week isometric test, and she was able to kick, I think, 12 pounds with her quad tendon graft side. And then we did focal cooling and just went right back on the machine. And she, I think, tripled her strength, got up to 35, 40 pounds, which was still less than I was hoping for at that point with her, but it was a lot. It was a really big improvement and shows the power that prefocal cooling can have. Sometimes it's tough to do that logistically in the clinic. If you've got a 45-minute appointment, the patient walks in 2 minutes late, and trying to spend 5 or 10 minutes of icing with them and then still getting what seems like a quality session in can be difficult, but sometimes it's worth it in order to get the thing that matters the most for them at that point.
Do you think, or do you have an idea as to what the prefocal cooling is doing? Is it just kind of numbing the area and dampening down the intensity of symptoms, and they aren't as limited by symptoms?
I won't pretend to be an expert in all the mechanisms of AMI. If you want to read some good papers, I'm sure we can link these later on, but Meredith Shaput and Dave Sherman have done some really good work in this. And those papers will go into all of the really fancy and complicated afferent pathways from the knee joint to the brain and how the brain changes after ACL. But their big recommendations for treating arthrogenic muscle inhibition when your quad just doesn't come back after ACL surgery are that prefocal cooling, using TENS along with the NMES and having TENS around the knee joint, similar to the prefocal cooling, as well as hammering BFR, NMES, and some overloaded eccentrics on both the surgical side and the non-surgical side.
Outside of just the trickiness when these quad tendons are in a really tough spot, like you said, there's a spectrum of how they respond. But with just the nature of the position of the graft and what was utilized, is there anything from a positional standpoint for loading of the quad tendon or the rehab as a whole, outside of the maybe trickiness of the symptoms and the quad output compared to a bone patellar tendon bone?
So because it is taken from the rectus femoris, and we talked about how that crosses the hip joint, when the patient can tolerate the load at their quad tendon graft site, I tend to do a lot more knee extensions with the hip extended, whether that's reclining a normal knee extension seat back and having them lean back. On our isokinetic machine, we can drop the back completely flat and have them completely supine on it, or you can go prone and put a band or some sort of cable machine in order to kick into that to make it hip extended positions. So I think hammering that to load the rectus femoris and to try and bias that compared to all the other quad muscles, just because that's the one the graft was taken from, can help a lot. One other thing we tend to see a lot of, whether it's due to the graft site or just the decreased quad strength, is they struggle a lot more than patellar tendon grafts in loading their knee and their quad in positions of deep knee flexion, especially with speed. So these are things that all ACLs struggle with, but I think quad tendon grafts tend to struggle with more. So one of the things going back down was force plates. When you talked with my boss about this, if I'm looking at a single leg counter movement jump on a quad tendon graft site leg, they'll have a lot shallower depth and counter movement depth. They aren't going to be dropping as low in that single leg counter movement jump than they will on their non-surgical side. And that's one that can take a long time to come back.
And is that pretty much because of the ultimate quad abilities of just eccentrically being able to load it and its overall capacity and symptoms?
Yes. So I think it's mainly due to the fact that it's usually slower, just overall quad strength, and then trying to recruit that quad strength quickly, eccentrically during the drop of a single leg counter movement jump. I think the quad tendon grafts just struggle with that more because of the overall lack of quad strength.
You mentioned, or we just discussed, for patellar tendon, you're treating it kind of like a tendinopathy. The quad tendon, it doesn't sound like that's the case because they're more finicky, or what's the difference?
Yeah. So we've seen with our quad tendons, once we get one of the graft site pissed off and really angry at us, it can take a lot longer to calm down and be able to handle load than a normal patellar tendon graft or even just a quad tendon tendinopathy. So we're the second opinion for a lot of ACLs in this area. And a lot of times the cases, they're coming in at 6 months, 9 months, 12 months to our clinic. We do a strength test and they're at 50, 60% symmetry, really low torque to body weight numbers, and they're limited due to the graft site pain. And so we have to spend then 2 or 3 months just slowly loading it, letting it calm down, and not even hammering high intensity quad loading in order to let it calm down. So in order to prevent that from happening for our patients that we see from post-op day one all the way throughout rehab, we're backing off a lot more on pain allowed and even how aggressively we get with open chain loading for the quad tendons early on. So my usual rule of thumb, especially for the quad tendon grafts, is no pain for the first 12 weeks at the graft site, even if that means that they're kicking lower numbers, we have to use BFR for longer, or we're having to alter the sets and rep schemes in order to keep the load low to keep the graft site happy. I found that keeps the graft site less painful, which then when we get into mid stage and late stage rehab allows us to load heavy enough and frequently enough that then lets us get back to sport without being limited from the graft site pain.
This is kind of a side conversation, but out of curiosity, when you're getting these second opinions, these ACLs that are coming to y'all, like you said, maybe 6 months out, a little bit shorter, a little bit longer, and they're obviously well below where they maybe should be. How do those conversations go? And are a lot of people that are coming to you all, the athletes or the patients, kind of already expecting and assuming, okay, this is going to take quite a bit longer than maybe that initial timeline they were told? Yeah, I'm curious how those conversations and that transition of care to you all looks.
Typically, it goes better than I expected, just because they're getting sent to us for some reason, whether it's a surgeon in town seeing, okay, you're not making progress at the 6-month follow-up with me, we're going to go send you to this other clinic, see how they do, or get their opinion on stuff. Or they're getting referred from a current patient of ours, a family friend who's sending them to us. So they have kind of already a little bit of buy-in just from the word of mouth. And then the fact that we can put hard numbers to it with testing, and this will go back a little bit to the Instagram post that sparked this all, but we can compare, hey, this is where you're at now. This is where we would expect you to be. And this is what you have to hit before we can have you start running, jumping, going to practice, playing your sport again. So it's really easy to lay it out for them in a stepwise fashion rather than just be like, yeah, you don't seem completely right. We're going to try some things and we'll kind of just go off of eyeballs and see how you do. Being able to put numbers to it and show the progress and show the current deficit and where we need to get to tends to help.
Anything else with quad tendon you want to touch on before we go to hamstring?
I think that's everything I had for quad tendons. I think the big things to come back to for that are don't let the graft site get irritated and be really slow early on, but then really aggressive later on in pushing the quad strength because they're going to struggle with the strength, but you can't get the strength if the quad tendon graft site is pissed off.
Okay, let's transition to hamstring tendon, wherever you want to start.
Yeah. So hamstring has fallen out of popularity a lot in the past 20 years or so, just because it was the super quick return to sport in 6 months promise because your quad strength doesn't drop and you can just fly through rehab. But then when you start re-tearing it and it's much higher re-tear rates than quad or patellar tendon grafts, it's been a lot less frequent of a graft choice now for a lot of surgeons, especially with high school or college athletes. So we also don't see as many of them here in town, a lot less than our patellar tendon or quad tendon grafts. But the big things that we see with them are it's usually with patients who aren't skeletally mature enough to get a patellar tendon graft. And so they have to default to the hamstring graft. Easy things are you don't have to struggle with donor site morbidity when loading your quads. So you can hammer those quads early on right away. Unless their patellofemoral joint for some reason gets angry, you usually don't have any issues with it. And so you see much higher quad strength numbers throughout all of rehab. The handful of downsides in rehab are it's a lot because you're losing a hamstring tendon, it's a lot harder to then get your hamstring strength back, especially in deeper ranges of knee flexion. So you can see this a lot when you're having a patient doing later stage stuff and you're having them do a little warm up and they're doing butt kicks. And you can just watch from behind or from the side and see, okay, they're good leg, they're able to get their heel within an inch or so of their butt. Maybe they're hitting their butt, but then their surgical side, they're stopping 6 inches short because they don't have that deep knee flexion active strength in order to get it up there. And then that also can expose itself a little bit if they're in a sport where they're sprinting a lot. They might be a little bit more likely to strain a hamstring or struggle with sprinting due to that as well.
Are you combating that with some of these end range or deeper knee flexion isometrics or isotonics? Are you still staying with more of the mid-range or longer stretched position because that's going to have the most load? How do you all navigate that?
So I think from essentially day one, because we don't have to work as hard to get their quad back as their hamstring, the almost ratio of exercises from quad to hamstring in throughout their entire rehab is a little different for them than a patellar tendon or quad tendon graft ACL. So we're just hitting more hamstring stuff throughout all of it. And that's all your classic hamstring exercises, RDLs, hamstring curls, Nordic hamstring curls, glute ham raises, everything like that. And then when their strength in those shallower ranges of knee flexion, whether it's isometrically at 60 degrees, 30 degrees, or even isokinetically gets symmetric, then we start both training and testing in those deeper ranges of knee flexion. So big things for me with the knee extension hamstring curl machine we have at our clinic, I can set someone up in essentially a knee extension starting point, but then instead of having them kick out, I can have them push in with our machine setup and have them do a yielding isometric at 90 or 100 degrees of knee flexion. That tends to work pretty good, as well as setting up, trying to figure out a good way to picture this or draw the picture for patients, almost like you're standing, holding onto a rack. You get one of the split squat roller pads that you would use for like a Bulgarian split squat, and you tie one of the mini TheraBands around it, loop your heel underneath that, the other end of the band under the pad, and you're just doing almost end range lift offs from 90 to 100 degrees or 120 degrees of knee flexion against that band to isolate that deeper range of knee flexion.
I haven't tried that standing, but I've tried like a kneeling or half kneeling component where that surgical limb that is that knees in the trail position, it's on the ground, and then that foot is essentially like on a medicine ball, and then you're like lifting that foot and actively contracting that hamstring. So essentially the same thing. I like yours because you have that mini band resistance into it as well. Are you similar to the patellar tendon and quad tendon question? Are you treating these like a kind of tendinopathy? And do you notice that some of these will get pretty cranky in the donor site region?
I would say it might just be due to the lack of overall hamstring graft ACLs we see here, but I've never had an issue with the hamstring tendon graft site becoming painful with hamstring loading. Um, Anecdotally, a handful will say it feels like it's going to cramp more than the other side does, but I've never had anyone have any pain that limits their hamstring loading after this graft.
Anything else with hamstring tendon before we dive into y'all's findings with the overall testing of all three?
I think the one thing I'll add in for hamstring grafts, and this also applies to allografts as well, is because the muscle recovery goes a lot quicker with this than the patellar tendon or the quad tendon grafts do. You tend to have to hold these patients back a little bit more. With the quad tendon or patellar tendon, a lot of times things just kind of come together at the same time if the rehab's going well, where right around 6 months, 7 months, where the surgeon's comfortable with them going back to some practices, their strength's getting right around there. And then at that 9, 10, 11 months where biologically the graft is healing enough that they could return to sport, their strength is getting right around there, and all kind of just happens well. But for hamstring grafts and allografts, oftentimes just for pure limb symmetry index, they're symmetric for their quads and depending on how you test their hamstrings at 6 months. And so the patient's like, why can't I go back? I have the strength. I feel like I can do it. And so that requires a lot more education on your part about the graft itself, how it's maturing, how it's healing, and how it isn't strong enough yet to be put to all of the demands.
Yeah, that makes sense. I appreciate you giving that caveat. Do people have pushback on that, or are they understanding when you set that expectation?
I think it tends to be received well just because the patients getting this graft for allografts tend to be older in general, a little bit wiser than teenagers or people in their 20 are, and a little more understanding of all of it. And then hamstring grafts also tend to be either a little bit older or a lot younger, where they're 12, 13, 14 years old, aren't skeletally mature enough to get a patellar tendon. And at that age, oftentimes their parents are a little more in control of their life than when they get to 16, 17, 18 years old.
Do you want to dive into some of these 6 months findings and the recent post y'all put out, and we can go from there?
Yeah. So at our clinic, we've obviously have a lot of ACL patients. We do a lot of strength testing on our iSkinetic dynamometer. And so one of my projects about 6 months ago, maybe a year ago, was to start compiling all of the testing data from the years our clinic has been open. And so I did that, finished up about 6 months ago. And then when I was redoing it and updating with the past 6 months of results, I got it. And one thing we hadn't done earlier on was separate it out by graft type. And so I was talking to Laura, the owner, and just asking her, what do you think the numbers are going to be difference-wise between these two? And so she made her guess, I made my guess, and then I went and we just picked 6 month time point because it's rare a patient is discharged and leaving PT. We aren't testing them anymore like it would be at 9 months or a year. And there's still enough of a data of a population. Everyone's testing pretty much at that point. So we chose that. And then we got both isometric and isokinetic limb symmetry indexes, as well as torque to body weight goals, and compared them between grafts. So obviously it's not a perfect research setting where we have the same amount of grafts for each different one, same amount of patients for each graft type. But so we have a lot more quad tendon than patellar tendon than allograft and hamstring grafts. But we did see a very big difference between the different graft types in all of this. So just reading out these numbers, quad at 6 months out, isometrically, quad tendon grafts are at 58% symmetry, patellar tendons are at 79%, allografts are at 82, and hamstring grafts are at 98%. So obviously these are averages. We got some patients who do a lot better, some patients who do a lot worse than that, but it is a large difference, even just talking quad tendon to patellar tendon, both taking it from your extensor mechanism of your knee. But at 6 months, at least in our clinic, there's a 21% difference in symmetry at that point. Same thing applies for isokinetically at that time point. Quad tendons were at 53%, patellar tendons were at 73, allografts at 80, and hamstring grafts at 87%. So even isokinetically, then there's still a 20% difference between quad tendon grafts and patellar tendon grafts.
And with your looking into the research and comparing these findings across the three autografts and the allograft, is that comparable? Is that generally different to what the research would suggest at the 6 month mark?
I think it's pretty similar in general. So I was looking through a couple of different studies, especially right before we got on to get some specific numbers on this. The trouble is a lot of the research that was being published 10, 20, 30 years ago is when a lot more hamstring grafts were being used. And so if you look at just the research, limb symmetry indexes might seem really high if you're seeing a lot of quad tendon grafts in your clinic nowadays and you're comparing it to the research from 20 years ago and you're wondering why your numbers are so much worse than the research. But then as more stuff comes out lately about quad tendon grafts, you do tend to see the quad tendon grafts are a lot lower than patellar tendon, which are lower than hamstring tendon grafts. So one recent paper that came out that was really good on this was it was a multi-center study by the lead author was Weaver. Chris Coons was involved in it. I think it was at a couple different university sites, but it was titled Isokinetic Knee Strength and Patient-Reported Outcomes Differ Between Graft Types in Adolescents After ACL Reconstruction. So they did all their testing at 8 months out, and this was an average of 17-year-olds. So if you're seeing a lot of high schoolers, this would be falling into that range. If you're seeing college kids, this might be applicable for them too. But at 8 months out, their quad isokinetic strength was at 78% symmetry, patellar tendon 72, hamstring 87. So those are all a lot higher. But then the other thing that's important to look at is their torque to body weight ratios. So for all of these, they were relatively symmetric at 8 months out, but they were not that strong in general. They're for quad tendons, isokinetically, they were at 52% of body weight. On patellar tendon bones were at 56%, hamstrings were at 59%. So for all those, if we're converting it to, a lot of times people use Newton meters per kilo, that's hanging in the 1.5 to 2 Newton meters per kilo for body weight, even with a hamstring tendon graft isokinetically at 8 months out. So that is important to note. You should be looking at both symmetry and how strong you are compared to your body weight.
Yeah, the numbers are kind of inflated because of just not great performance on the either limb. Yeah. Shout out to Nicole Sertica, who's been on multiple times. She had a post or a story recently about her experience with quad tendons because there's been more talk about this, and where she currently is at Phoenix Children's, she said hers have gone pretty smooth. And obviously, region by region and different clinicians you talk to, there's going to be variation of how people's reactions are and their response with their athletes and patients, depending on the graft and the region. What would you say has been kind of your experience or conversations with other clinicians that say, oh, these type of grafts are smoother, I actually have the opposite, and vice versa?
I think the vast majority that I've talked to echo the difficulty in getting quad strength back, and especially faster rangers. If you're testing isokinetically or testing rated torque development, it tends to be a lot harder with a quad tendon graft than other ones. As far as the graft site pain, one thing we've noted is we see, because I'm in a college town and then there's a bunch of different orthopedic surgeons in this town, we've seen a lot from a lot of different surgeons. And with it being a newer graft as well, getting more popular in the past 10 or 15 years, while PTs are figuring out how to rehab this graft, I think surgeons are also kind of figuring out getting their skill in the surgery up as well. And so I think there is a lot of variability depending on the surgeon and the patient in how much the graft site pain limits you.
To the findings that you all had, and also comparing that to the literature, reiterating the 6 months out on average, the isometric quad limb symmetry for the quad tendon is at 58%. In general, are y'all finding just a longer return to sport and pushing that timeline out compared to a patellar or a hamstring, or things kind of normalize around the same timeline?
I think it tends if a rehab goes well, it's a patient, an active patient, an athlete with a quad tendon graft. I'll say it can be pretty similar to a patellar tendon or a hamstring tendon graft. But when speaking on average for the general patient, I tend to tell people hamstring graft, we should be right around 9 months. Everything should be smooth. I don't think we'll have any issue getting strength back. Patellar tendon, I'll tend to give a timeline. It's going to be 9 to 12 months on average. We might struggle a little bit getting the last end stages of rehab, getting your isokinetic strength back, getting your rate of torque development back, getting all your jumping to normalize. But in general, we can expect 9 to 12 months for rehab. Quad tendons, I tend to push that out even more and just set the expectation. We're probably in this for at least a year. If things go slow or we run into some road bumps, it's going to be looking at a year and a half for rehab, which for a lot of patients don't like hearing that, especially if they're a high school or college athlete. They tour in the middle of their season and it's, hey, I may or may not even get back for next season. But then we also see a lot of general population patients, a lot of people late 20s, early 30s who get this, who are recreationally active and skiers. And those are the ones who tend to struggle a little bit more in getting their strength back just because they have more life stress going on. They aren't a high school or college athlete who can dedicate their life to this rehab because they have a full-time job, kids, a lot of work and life stress to deal with as well.
And I'm sure y'all track a lot of other things outside of the limb symmetry and the torqued quad or torqued body weight and just performance metrics. Are y'all tracking re-tear rates or just the differences in re-tear rates from these different grafts from your previous patients?
So thankfully, we haven't had many re-tears, so it's going to be a little bit skewed as far as this. From at our clinic, from what I'm aware of, since I've been here, we have had 2 quad tendon grafts re-tear, one of which I know wasn't symmetric, went and played a sport, and it retore. I will say his other leg also broke our humac because it was so strong and kicked over 400 foot-pounds and slowly wore down the humac and then eventually broken. We had to get a new piece for it. As far as other graft types, we've had some contralateral tears for both quad tendons and bone patellar tendon bones, but no re-tears of the actual grafts for those. And then we've seen a lot of hamstring grafts that were done previously when a patient was in high school. Now they're in college and it re-tears, and then they go get a different graft type. And then finally, getting a little more away from these, I've had one in a really young, we've had a couple actually in really young patients who had to get a physis sparing IT band graft that ended up re-tearing a couple years down the road as well. So I don't think there's a drastic difference, at least in our clinic. In the research, it tends to see quad and patellar tendons have similar re-tear rates, with hamstring and allografts being higher.
And do you think the hamstrings are at a higher re-tear rate because of what you said earlier? People are just going back sooner and they're not as prepared as if they were to wait. Let's say they go back the 6-month mark versus 9 or 12, and there's just a better development of their overall system. Or do you think there truly are significant limitations that is increasing the risk?
So from what I've seen and what seems to be in the research, I don't think patients with a hamstring graft are going back with massive muscle deficits if they're going back early. I believe that was echoed in a lot of Rula Kristofaki's work when you had her on and talked about the paper, I believe is 9 months the sweet spot for it. I do think if they are going back and re-tearing early, it is likely due to the fact that the hamstring graft is a weaker graft, and then they're also pushing it earlier when the weaker graft itself hasn't even reached the maturity level that a quadripatellar would at that time.
And if you're getting patients coming in preoperatively and they're seeking your opinion and you're having this discussion of the pros and cons of these different grafts, what is your general spiel and what are the things you think other clinicians should consider when discussing with patients and potentially their family members that are maybe in between surgeons or the surgeons have given multiple options? What are your recommendations?
So yeah, it definitely depends if they've seen a surgeon before, because just for continuity of care, if they've already picked out their surgeon and I know what graft that surgeon does, I'm just going to be echoing and almost championing that graft just to build confidence in it for them. If I see them tear it, they come into us because they know us and they haven't seen a surgeon yet before. I'll talk through all the different graft choices and kind of lay out almost like we've laid out in here, just in a much shorter, less detailed form. And then give them names of a couple different surgeons who I think will be both a good personality mix for them, because I think that matters a lot, especially when you're going to be seeing that surgeon for the next year, 2 years with follow ups. And then surgeons who I think will both listen to the patient with their choice of graft, and then if I'm deeming one graft is probably the best for the patient, I want to make sure that surgeon at least does that graft and will provide it as an option for them.
Anything else with this topic as a whole before we wrap things up that you want to touch on?
I think the one big thing to touch on, at least with kind of the reason for all this with the testing, is I want to make sure to talk about with testing when if you're only testing patients isometrically for a 5-second peak torque test, you might be missing a lot of deficits with other things as well too, especially with a quad tendon and to some extent a patellar tendon graft. So making sure if someone is symmetric or hits their torque to body weight with a 5-second isometric peak torque test after ACL surgery, that's the bare minimum they should be hitting. And if they're just barely hitting that, that means they're probably going to be worse with an isokinetic test. They're probably going to be even worse with a rate of torque development test. And their jump testing also is likely not symmetric at that point. So making sure you're not just barely hitting isometric testing and saying you're good to go, and making sure you're covering all your bases with this too.
Yeah, if someone, and a lot of probably the vast majority of people listening don't have access to isokinetics and they just have an isometric setup that they've rigged together, and or maybe let's say a force plate if they're lucky, or just like my jump, is it just acknowledging and to both the patient and yourself as the clinician, hey, I probably need to get these numbers higher than I would typically, because I know that if I were to test isokinetically, it's probably going to be lower. And then with the jump testing, you're probably going to see those, like you said, rate of force changes and just the overall kind of qualities of the jump.
Yeah, so I think if you obviously don't have access to an isokinetic dynamometer or force plates, 'cause a lot of clinicians just don't have that access, there's a couple of different options. One thing would be with just you doing an isometric peak test, set your targets even higher. If you're barely hitting 3 newton meters per kilo and 90% symmetry, bump those up to 4 newton meters per kilo. If you hit that, then you can have higher confidence that all the other things will be going well. If you have an isometric setup with, say, a Tyndek or a Vault pull dynamo, you can shorten the test rep of it. So instead of having a 5-second peak torque test, having it be a 1 second or a half second and seeing how symmetric the patient is with that. You can always try and find a place nearby that has isokinetic testing, whether that's another clinic or a lot of colleges and universities will have access to it, especially if they're doing ACL research. And then finally, for jump things, if you don't have access to a force plate, I love the My Jump 2 app. And the simplest thing would be with a single leg vertical jump, watching counter movement depth, like I talked with a quad tendon graft, and then just jump height, one leg versus the other, because that is a culmination of both rapid eccentric loading and deceleration, and then having to rapidly concentrically propulse up on that leg too. If someone can do a symmetric and good looking single leg vertical jump, then you can have a pretty high confidence that their strength testing, both isokinetically or with rate of torque development, would be pretty symmetric as well.
We'll call it there. Thank you so much.
Thank you guys for having me again. This was a fun talk.